so much, Julajat, for the kind introduction, and I have to thank Johnson Immunology as well for inviting me here to be able to present Best of DDW. This is my second time in Thailand in the last few weeks, actually. So yeah, it's great to be back. So my task is to talk a little bit about, the introduction of the Best of DDW. So these are the disclaimers. So Best of DDW was actually created by these cornerstones, where we convened 37 experts of IBD faculty from various countries, and there are 7 different teams depending on the categories. The team then investigates all the best, all the posters, abstracts from DDW during this time, especially the fellows. And then after that, after DDW, each team presents their slides, and then the final selection is made after voting, and then after that, the slides are reviewed and modified and presented across various different countries. So that's the whole basis of it. This is the Best of DDW faculty, of which Malcolm and I make up part of the Asia-Pacific one. And these are our fellows who actually do all the work. So thank you to the fellows, because they're the ones that attend most of the sessions and create the slides along with cornerstones and present to the faculty. So these are the 7 subcategories, and I'll be talking about the first few. So I'm just going to select the ones that I like, and I think what I think is very clear is that in the past, we were not very good about diet in IBD. You know, when patients ask us, what can we eat, what can't we eat, we didn't usually have a lot to say. Exclusive enteral nutrition and things like that, although of course is effective, is hard, to be adherent to. But this has changed over the last years, I'm glad to say. And again, more and more data is looking at dietary factors associated with risk of flare. And there are 2 studies here that I want to present. One is among the Hispanics, but showed that when you have a high intake of starchy vegetables, this was actually associated with lower clinical and biochemical activity. The second study is from the PREDICT study in UK, and this is also a large study including pediatric centers as well. And this study looked at other things, including the intake of meat, and found that habitual meat intake was associated with flare in UC, but not Crohn's disease. So I think it strengthens this idea of an anti-inflammatory, pro-inflammatory diet, where essentially if you eat more fiber, more vegetables, more plant-based proteins is probably better than, and we know things like ultra-processed foods, emulsifiers, high refined sugars have been linked with IBD in the past. I was very happy to also find out and present data right here from at home by Julaja. It's a beautiful study looking at 61 IBD patients with clinical remission and given dietary advice. It's a very, very nice study, high fiber, high plant protein, pretty much what I just said earlier. And what makes the study even more meaningful, I think, is the fact that he also did a microbiome profile and actually found that by having this healthier diet, there was a reduction in clinical relapse, increasing in the good bacteria, the Clostridium bacteria, and and a trend towards reduction in calprotectin level as well. So I think I once likened it to patients with diabetes, where in the past, you would never tell a diabetic patient, take your meds, but eat what you like. And I think this is coming to that way for IBD as well. It's not just a matter of taking your meds, but you probably also really have to watch what you're eating. The next thing I wanted to present was on the epidemiology of hospitalization for IBD. So this is seen in Taiwan, a very big study, actually 4,430 patients, where we know that IBD is increasing in this part of the world. So of course, the overall hospitalization is increased in keeping with increased incidence and prevalence. But like in the West, I guess because we're managing it better, there is decreasing rate of hospitalization when you compare to all IBD patients, length of stay, and more prominently, what you're also seeing is this decreasing surgical rate as well. And this is very much in keeping, especially for ulcerative colitis, all right? Not decreasing yet for, so you can see here, sorry, the decreasing rate from 8.6 to 3.4. Now let's move on to current and emerging therapies. So let's start with a polling question. Can everyone vote? Excellent. Okay, I like it because, there's a whole, there's a whole range here. So let's see if the next few abstracts gives us the answer. So this is just an overview of the treatment options in IBD at the moment. So we talked about dietary treatment. Of course, by that we mean mainly oral nutritional supplements and enteronutrition or parenteral, which is still mainly effective for Crohn's disease. 5-ASA only for UC, and we'll having an abstract about that later. Steroids we know is used for induction, of course, but not for maintenance. Thiopurines, not for induction, because that's been shown by the big JET studies and all that, but for maintenance. Methotrexate is important to understand that all the studies on ulcerative colitis have been negative. And then now we come on to the advanced therapies, and these are the biologics, as you can see here. But the newer ones that are coming are the novel small molecules like the JAK inhibitors and the sphingosine 1 receptor modulators. Stem cell is mainly for perianal Crohn's disease, but the latest from Takeda showed the final results of the ADMIRE study was negative, so whether or not we'll be able to use stem cells on a wide scale, unfortunately, remains to be seen. What are the so-called small molecule drugs, or more the novel small molecule drugs, because of course azathioprine and methotrexate are also small molecules, but the difference is that these drugs specifically target important pathways, and the advantages over biologic therapy is that you have oral administration, and because they're not large molecules, all biologics, not just infliximab, are very large molecules and have the potential for the development of antibodies which can neutralize and result in the lack of loss of response, and this is one of the advantages of the new small molecules. And what are available at the moment, the most important for sure is the JAK family. So these are the non-receptor protein kinases. They're enzymes, they're intracellular enzymes. And what they do is that they transmit the cytokines, all right? They're involved in the transmission of cytokines which are involved in inflammation. So if you can see here, for example, IL-23, which is a very important cytokine in the pathogenesis of IBD, that's mainly transmitted through the JAK2 and tyrosine kinase 2, for example, but multiple cytokines are transmitted across the board. And so, and they have very, very specific effects. And JAK1, for example, is important in decreasing inflammation. And all the others do as well, but for example, if you had JAK2 inhibition, this could result in undesirable side effects because it blocks the transmission of erythropoietin and may exacerbate anemia of chronic disease. And how does that apply to the drugs that are available? Well, you've got tofacitinib, which is the original JAK inhibitor that was licensed for ulcerative colitis via the landmark OCTAVE studies, and it is a pan-JAK, so it is potent, but theoretically may have, the additional adverse events as well, such as anemia. On the other hand, JAK1 selective inhibitors theoretically should have high selectivity for decreasing inflammation without perhaps some of the other adverse event profile. That's the theory anyway. So, and the two that have been studied are filgotinib and upadacitinib. And I'll be presenting the latest data on upadacitinib. Now, I'm not going to talk about the landmark studies on upadacitinib. First of all, the main ones have not come out yet. But what I wanted to highlight were a few key notes. So this is coming to perianal fistulizing Crohn's disease. How many people use how many people use infliximab for perianal fistulas? Show of hands. Right. Okay. So I hope we're using biologics for perianal fistulizing Crohn's because steroids don't really work. But the recommendation generally, for example, the AGA guidelines, is infliximab because that has the best data, and you can use the others, but the data is not so strong. All right. So what is interesting, however, is that upadacitinib is actually showing very strong data for fistulizing Crohn's disease, and this is phase 3 data, which is a subgroup analysis from the UEXCEL, UEXCEED, and UENDURE study. So these are the multiple protocols from the upadacitinib in Crohn's disease, and what you found here was that at week 12 and subsequently at week 24, so this is using the induction dose of 45 milligrams, where there was much higher external closure, resolution of draining, and clinical and endoscopic response and remission in the induction group compared to placebo, and this was maintained in the maintenance group at 15 and 30 milligrams. So I think this is quite interesting that we now be able to use upadacitinib as part of our armamentarium for perianal fistulizing Crohn's disease. The other thing about it is that it can also, it has a fairly good safety profile, even in pediatrics. So of course it has, always with pediatrics, licensing takes a bit longer. But you can see here that in this study, there's also an acceptable safety profile. This is a retrospective study in patients who are using this. And you can see here that is both effective with a good safety profile. So as I said before, tofacitinib was used, is the first drug to be licensed in ulcerative colitis. Yeah? Basically, what about those who failed tofacitinib? So this abstract is interesting because in this study, upadacitinib is effective even in patients who are tofacitinib experienced. So in other words, it's still a JAK inhibitor, but may show increased potency. So study 1 just had a combination of things, including patients who are exposed to tofacitinib. But in study 2, although it's a very small one, specifically looked at tofacitinib experienced patients. And although the numbers are very small, you can actually see here that the clinical response at week 4 and subsequent week 8, is as high as 87%, so very, very high with a marked reduction in calprotectin from baseline. So it does suggest that even in patients who failed the pan-JAK tofacitinib, upadacitinib shows a lot of promise. What about acute severe ulcerative colitis, which is a problem? We know the rescue therapies failing steroids are infliximab and cyclosporin. These are the ones that are mainly used, but this is a one single center series that showed high intensity upadacitinib may be used as well, but they used a dose of 30 milligrams BD. And you can see here that these patients were followed up by 90 days, which is standard for acute severe ulcerative colitis. And you can see that steroid-free remission was achieved in a significant number of patients and not really too much in the way of adverse events. I wanted to show my own case just to highlight somebody where I was rather desperate and I used it. This patient had been tried on many things, actually, and presented with acute severe UC. This is just an example of some of the endoscopic pictures where I did give a high dose of upadacitinib because she had a lot of bleeding, she was anemic, and she was going like more than 10 times a day, and she did achieve, as you can see here, good endoscopic response, good clinical response, but although not complete remission. So now let's go on to the next polling question. So can we have the polls, please? Okay, so that's Again, very good. All right. Okay, so let's look at some data. So I think this study was looking specifically at tofacitinib, and it's a real-world retrospective data, and ustekinumab. And what they found was that both tofacitinib and ustekinumab had similar effectiveness in terms of after anti-TNF failure, 289 patients. But what they did find was that if you look at predictors, with tofacitinib, they could not predict success or failure, but in ustekinumab, they found that the more exposure you had to biologic therapy, the more likely you have a chance of having failure. So it does suggest, I think, in my mind, although we need more studies, that perhaps in patients who failed biologics, things like small molecules like tofacitinib, maybe upadacitinib, may be the way to go, as opposed to trying multiple biologics. But I guess we need more data, maybe more prospective data on this. But what about it? And when you compare tofacitinib to vedolizumab, which has really been the mainstay of biologic therapy, I think, to a large extent for ulcerative colitis, you can actually see that, in fact, tofacitinib had a higher odds ratio of steroid-free clinical remission and endoscopic remission at 52 weeks if you compare them if they had failed an anti-TNF. So again, suggesting that tofacitinib, versus vedolizumab, tofacitinib had a better outcome. Moving on to sphingosine-1 phosphate modulators. So what are they? These ones trap the lymphocytes, all right, in the lymphoid organs and prevent aggression of these lymphocytes to areas of inflammation, i.e. the gut. And there are two that are being studied for ulcerative colitis is ozanimod. Okay, so the differences between them, as you can see here, all right, there's just a difference. Ozanimod reduces, they both reduce lymphocytes, of course, by default, but slightly different in terms of half-life. Ozanimod has this potential of bradycardia, so this is an important thing that is looked at in all the clinical trials right now with the sphingosine-1 phosphate inhibitors. Etrasimod is a little bit, has a longer half-life, but has a modest first dose heart reduction. So that's why in those sphingosine-1 modulator studies, baseline ECG and serial ECG monitoring is quite important. The first drug, sphingosine-1 phosphate modulator that was looked at is ozanimod, and this is the True North study. So this year's DDW was presenting data of up to 3 years, which really showed that those in the open label extension had still maintained high endoscopic histological remission and mucosal healing at 3 years, and a good safety profile, all right? So very few in terms of side effects, mainly a bit of lymphopenia, which you might imagine, anemia and nasopharyngitis, no major discontinuations from bradycardia or MACE, which is the major adverse cardiovascular events. Etrasimod, which is the newer drug, is been looked at, and this is the Elevate UC52, and this study, is showed very high, high rates of corticoid steroid free remission and endoscopic improvement and symptomatic remission as well, all right? So, and again, when you look at the safety profile, it seems very good. You can see the serious infections here is not too different compared to placebo, with no significant signals for herpes zoster. How many people use 5-ASAs for Crohn's disease? Sometimes I do as well. The purists don't, but some of my patients have been started on it, and I have to admit I keep it. But most guidelines state very, very clearly that you shouldn't be using 5-ASAs for Crohn's disease, unless for very mild colonic Crohn's disease, when there's a little bit of data on sulfasalazine, okay, if you look at the meta-analysis. So this study was very interesting because it shows you very clearly that even in mild Crohn's disease, 5-ASA is not superior to no therapy. So I think, and you can see here, this is in patients with no maintenance therapy, in patients with maintenance therapy, absolute no difference to anything. And again, highlights that perhaps people should not rely on 5-ASAs for Crohn's disease. Even in the mild ones, you should be doing induction therapy with whatever it takes, of course, and perhaps maintenance with immunomodulators instead. Now let's move on to the current and emerging therapies with biologics. Infliximab is our original drug. It's still a drug I love very much, but it's expensive, and it's good that multiple biosimilars have come, but a lot of physicians are still very scared. And this is a very interesting study because they didn't just switch to one biosimilar, but they switched to multiple biosimilars, all right, up to 3. And essentially, a cheaper biosimilar comes out, they switch. A cheaper biosimilar comes out, it's switched. And it's switched multiple times. And this study is very nice because it shows that despite multiple switches, you still have drug resistance. You don't see any change in the effectiveness. You can see here with partial Mayo score, calprotectin, and no real signal with immunogenicity as well. So I guess my take-home message is the cheaper, the better. Use it, all right, whatever's available, as long as, of course, that we know that the product is licensed properly and has got good data. The other interesting thing is subcutaneous infliximab. One of the best things about subcutaneous infliximab is if you look at the trough levels of subcut infliximab, it can reach trough levels, maintenance trough levels of 20. And this is something IVs usually would not do. You know, if you look at week 8, for example, and finally there's data now on subcutaneous infliximab. See, this is the landmark study, Liberty, Crohn's disease, where you get an IV induction of 0, 2, and 6 weeks, and then after that they were randomized to subcut infliximab every other week, 120 milligrams, with the possibility to increase to 240 if there's inadequate response at week 22. And you can see that the data here shows significantly higher response in all the efficacy endpoints compared to placebo. And this is the Liberty UC, which really showed more or less the same thing as well. I did like this study because I think Julajat talked about the Creole study on adalimumab and strict-ring disease before. That was a study that was published some time ago. And again, this study shows adalimumab and showing a durability in inflammatory strict-ring disease. So I think for strict-ring disease, this to me is indication for top-down therapy, i.e. starting biologics straight away. And I think it's very reassuring to know that if we start early, we may be able to stave off surgery in a significant portion of our patients. What about newer drugs? And I think we should be aware of ustekinumab, which blocks the P40 subunit, because P40 is shared by IL-12 and the IL-23. All right, but now, for IL-23, there's also the P19 subunit. All right, and the newer drugs are the pure IL-23 blockers because they only block the P19, all right? So ustekinumab, as we know, blocks both because of its blockage of the P40 subunit, but the pure IL-23s block the P19. So what are they? You've got ustekinumab, risankizumab, mirikizumab, and guselkumab are the ones that are mainly looked at in inflammatory bowel disease, and all are showing data of efficacy. I think they're all very good drugs. But I will talk a little bit about ustekinumab, which I think is available here in Thailand. So I think everyone should know how the dosing schedule is given. So first you've got your loading dose, and that's and then given one subcut dose at week 8, and then you can either do 8 weekly or 12 weekly, depending. But there is some small case series which showed that repeat IV loading, if there's a loss of response, may have benefit. Is that true? So this was actually answered by a prospective study called the POWER study. And unfortunately, in this particular study, they found that there was numerical improvement, but not statistically movement at week 16 in those with inadequate or response, all right, to ustekinumab. However, in patients perhaps with high-risk group, escalation to 4 weekly is associated with a high remission rate and a possible advantage to immediate intensification. So those where they found that there was inadequate response, 123 were escalated, and they actually found that there was an improvement in terms of the endpoints which is clinical and endoscopic remission. So I personally, in patients with inadequate response, I do use 4-weekly ustekinumab. Okay, my time is really running out, so I think I'm not going to do the polling question. You've got now a similar scenario like the first case, which is ulcerative colitis, but now you have a secondary loss of response to infliximab. Common. What are you going to do? Which drug are you going to choose? And I think this study is a large population-based study from Australia. And you can see here a huge number of patients where it is very clear that in this study, in bio-naive patients, the persistence was the same, across all the biologic therapies. But in bio-exposed patients, you can see here that ustekinumab has got the highest persistence. And what does persistence mean? Persistence means that these patients still remain on these drugs, all right? And that shows that it's effective and there's a good adverse event profile, all right? So I think this is very important. But what about the pure IL-23 blockers? Like I told you, so guselkumab is one of the pure IL-23 blockers, and their landmark studies for ulcerative colitis is the Kuala study, where basically they were randomized to either 200 milligrams IV guselkumab compared to placebo, and the endpoints were measured at week 12, and you can see here that it shows pretty promising data in all the efficacy endpoints compared to placebo. For Crohn's disease, the landmark studies are the Galaxy studies, and according to this dose-ranging study, the very, very high doses are used, but I think subsequently for gravity and all that, doses like 1,200 were not used anymore, but you can see that across the end, in terms of clinical remission and corticosteroid-free remission, very high rates with ustekinumab as the reference drug. Post-operative Crohn's disease is a very important problem because we know endoscopic recurrence occurs in 70% following resection and anastomosis. The POCA study was the landmark study looking at adalimumab, but this prospective study done in Europe also showed that when you start patients on vedolizumab straight away and scope them after 9 months, you can see here that your portion of getting IO, in other words, no recurrence, was much higher compared to placebo, whereas in the placebo group, quite a significant number of patients, in other words, when they did not receive vedolizumab or anything, quite a high number at 6 months already had I4 disease on Rutger's classification. So I have 4 minutes to spare. With that, I thank you and open the audience for any questions.
Any question from the floor, from the audience?
Maybe later on, maybe let Malcolm present his data.
Thank you for your fantastic summary. I'd like to tell everybody here, you might feel that there are a lot of medicines that's too far away from our practice from now, but I would say that this happened to me about 15 years ago when I was a GI fellow, that I did not use any biologics agent, and then it's first very expensive, and I thought that in Thailand biologics agent may not be in place, but now everything changed. We have 3 or 4 biologics agents, including small molecules, and in my clinic, because patients may be severe than in the past, and we have used biologics for more than 100 of patients. So I think in the future, when the price of the medicine comes down, and it is for sure, we will have a chance to use many of these medicines in the future. And thank you. Okay. Please, Malcolm.
Can you hear me? Yes. Okay. So I would like to thank the organizers. It's always wonderful to be back in Thailand. I think I come here quite often actually for work and pleasure. So I'll start off with the second segment for Best of DEW. The content is very heavy. I think it's a bit late in the year. DEW was earlier this year, but I still think there are valid take-home messages and points that we can all learn. So I'll start with a few poll questions. They're quite simple. It's just a matter of understanding where the audience is and for me to find out also how widespread and how different our practices are. So the first question would be this. Do you use intestinal ultrasound for IBD patients in your practice? It's just a yes or no answer. Hey, it's fast. Okay, I guess we know where this is going. Okay, so I guess most of us don't. To be honest, I don't as well, but I think over the next 1 or 2 years in my center at least, oh wow, that's a yes. We will be trying to incorporate the IUS in our practice. I think it's something that patients do want because it's very good. They don't need to prepare, they don't need bowel prep. And it's something I think we need to look forward to and develop our services for. Ken, second question. Do you use therapeutic drug monitoring when you use ND-TNF in your patients with IBD? Again, it's a yes or no. Do you use TDM? Yeah. Okay, so I guess it's about two-thirds. About two-thirds of us do use TDM. I think that's pretty consistent with most practices around the world. And the third question would be, ustekinumab is safe for use in pregnancy and breastfeeding. By now we know with the data that we have on hand, ND-TNFs are actually pretty safe for both pregnancy and breastfeeding. Now we treat through. But what if your patient is on ustekinumab? Do you think it is safe for use in pregnancy and breastfeeding? Again, true or false? Do you think it's safe? Good. So the majority of us over here think that it is safe for use in pregnancy and breastfeeding. I think it's very good actually. Most of us are on the same page. All right, so I'll move on to the second segment for the best of DDW. So the first segment will be on disease activity and monitoring and therapeutic drug monitoring. So this is a smallish prospective study that was done in Australia. It recruited about 32 patients, adult patients with acute severe ulcerative colitis. And what they did was that they measured the bowel wall thickness at day 0, day 3, and discharge. So in ASUC, you know your assessment is on admission. Your assessment is also after 48 hours. So if you do a follow-up scan at about 36 hours, and if you look at the bowel wall thickness, so what they found was that if the bowel wall more or less remained the same thickness, right, that means it did not reduce by more than 1 mm or did not reduce by more than 20%, these patients were actually more likely to have steroid non-response. So instead of performing a CRP, you can use an IUS that will help you as well. It's an additional data point. And this was fairly accurate with an ROC of 0.8. And if you couple that with Doppler change signals, you will be able to have a better ROC of 0.9. So perhaps this is one of the roles that you can use IUS for in your practice in adult patients with acute severe ulcerative colitis. And you can predict, if you can predict non-response earlier, perhaps you want to move to infliximab or IV cyclosporine earlier. So in patients who have had intestinal ultrasound, how does it corroborate with endoscopic findings? So the first study looked at pediatric patients, and which found that if patients did not have endoscopic response or remission, their bowel wall thickness tended to remain the same. So that this is a corroborative study. So this is probably the role of intestinal ultrasound in our patients with IBD. And the second study, which was a short study, which included patients who had Crohn's disease strictures and underwent surgery. That means the bowel was resected. And if they've had an ultrasound about 100 days before the procedure, what did the findings corroborate with? And what they found was that the increase in bowel thickness actually is due to smooth muscle hyperplasia in the bowel wall layers. And this is consistent with what we understand about muscular hypertrophy in patients with structuring Crohn's disease. This study was a disease severity index study. This was developed by the IO-IBD consortium. And what this severity index tries to do is tries to encompass different facets of the disease. So for example, there are 4 big categories, which is disease phenotype, inflammatory burden, impact of disease on patient, and prognostic markers. For example, fistula would come under disease phenotype, albumin and CRP would come under inflammatory burden, anorectal symptoms and pain would come under impact of disease, and also prognostic factors such as biologic use or steroid use. And these scores are weighted differently. So this was a prospective multi-center study done in various centers, including Europe and USA. And what they found was that if you had a disease severity index score of more than 23, you had a higher odds ratio of developing complications of the disease by up to 9 times. So this is something that I think will be quite useful because these are the scores that generally you use in your clinical practice. You may not quantify the scores, but these are the things you ask for. You ask for pain, you ask for diarrhea, you measure their CRP. So this could potentially be useful in identifying patients who are going to have a difficult course, and these are the patients that you may want to introduce treatment early on and early biologic use. Fecal calprotectin is something we are all very familiar with by now. We use it in patients with ulcerative colitis and Crohn's disease as well. And one of the questions that remain is that if your patients have an ileostomy, they've had Crohn's disease and they have resection done and they have an ileostomy, and you're worried about disease proximal to the stoma, can you use fecal calprotectin? Can you send the stool effluent from the stoma back? And what this study shows is that actually you can do that. It's a retrospective cross-sectional study, which is a limitation, but had good numbers, about 100 patients. And what they found was that a fecal calprotectin value of 59 was fairly accurate in distinguishing small bowel inflammation versus the absence of inflammation with a fairly good sensitivity and specificity. So for these patients, it is actually possible to send samples from the stoma bag and send it for fecal calprotectin. And an easy number to remember would be 50, which is kind of similar to what we use for stool samples for predicting inflammation. So the next few slides are some of the things that we kind of know, but we have more data to reinforce what we already believe to be true. So one of the roles, I believe, for proactive TDM is if you want to reduce the rates of immunogenicity. Prospective studies have been done and shows that if you use proactive TDM, it doesn't really translate to better clinical outcomes for the patient. But what if you want to prevent loss of response? Then I think that is where TDM will be useful. So in a retrospective cohort of IBD patients using infliximab and adalimumab at this center, what they found is that if you develop a proactive strategy, that means you treat to achieve a certain drug level, these patients are less likely to develop anti-drug antibodies, and hopefully that translates to persistence and durability of your treatment and less loss of response over time. And this may be useful in patients that you want to keep on monotherapy, and patients that are perhaps a bit older, you're worried about immunomodulator use. So proactive TDM could be something you use for in patients with monotherapy of anti-TNF. And this is something we are quite familiar with as well, and it has been shown before that high infliximab trough levels are associated with better outcomes in patients with perianal fistulizing Crohn's disease. So don't know if it is correlation or causation, but I think that it is reasonable to use a higher dose of infliximab in patients with perianal Crohn's disease or fistulizing Crohn's disease. And a quick glimpse into the future. This is a summary slide of 4 studies that were presented. The first study, you know how patients, when they come to clinic, right, they like to take photos and then they like to show you a picture of their stool, right? And you don't really want to see, but you already have to see as well. So maybe instead of showing it to you, they can show it to a computer. So the first study shows that analyzing the photos of stools is actually as accurate as sending for fecal calprotectin. So this is potentially something we can use in our future, where patients will take photos of their stool 7 days before they come and see you, and then and send it to this algorithm which predicts if there's going to be inflammation in the near future. The second one is also fairly interesting. So this is a device that you can install in your room if you have IBD. And this device actually analyzes how the person sleeps, how the person breathes, and how the person walks. And it can also predict clinical activity and predict a flare before it becomes clinically apparent. And it's also as accurate as fecal calprotectin as well. But that's a bit creepy, right? You don't really want to install something in your room that's potentially gathering your data. And the last 2 are computer vision quantification. So we know that when we do scopes for patients with IBD, especially for Crohn's disease. Sometimes our measurement is actually not very accurate. We landmark quite differently. Sometimes the sigmoid is so long, sometimes the transverse is so long, you don't really know where you are, or you think you know where you are, but you're actually wrong. So the computer can potentially do something, can be better. So the first one shows that if the computer vision is able to use automated ulcer quantification, and this method is actually better than using SES-CD to predict clinical remission, both steroid-free and steroid-dependent. And the last study showed that computer vision is also useful in scoring endoscopic activity and disease activity in IBD as well. So at some point in time, we will expect in the future, maybe if we do a scope, we can get a score quite quickly, and which tells us whether the patient is doing well, not doing well, or is going to do well or not well in the near future. So it's something to look forward to within the next few years. So we move on to the next segment, which is treatment-related adverse events, safety, and vaccine. So the background for these two slides would be that we know that patients have a higher risk of venous thromboembolism, especially patients who are hospitalized for severe flare, for example, in acute severe ulcerative colitis. So the take-home message for these two studies will be that if you have patients with ulcerative colitis, don't forget that they have a higher rates. They have pretty high rates of developing venous thromboembolism, and they may need prophylaxis for that. The second study specifically looked at patients who were admitted for ulcerative colitis, and if they had surgery, the risk goes up a few-fold. And these are the patients that you want to be worried about. If they have ulcerative colitis, they come in for surgery, you should really be thinking about prophylaxis against venous thromboembolism. And over time, it also shows that physicians like us are more likely to prescribe prophylaxis for these patients. So there is an increasing awareness, which is good. Another study, another slide, another theme on preventive health. So patients who are above the age of 60 or above the age of 65, we should really think about vaccinations. So we do have effective vaccines against strep pneumoniae, and it's something that we should remember in our patients who are a bit older. We know all our patients are getting older and older, and also we have more advanced therapies, especially with the use of anti-TNF and immunomodulators, and sometimes we end up using steroids to treat them as well. So always think about introducing vaccination in your patients in patients in your clinic. And the first study showed that the rates of pneumococcal vaccination were actually low in adult populations, but there were some factors. So if patients had pulmonary disease, they were more likely to be vaccinated. But I suspect maybe the vaccination is given by the primary care physician or a respiratory physician and not by us. And the second study shows that the efficacy. So patients who were vaccinated against strep pneumoniae, and if they had an infection, they were actually less likely to die, less likely to have ICU admission, and less likely to require mechanical ventilation. So number one, the first message is get the vaccination status up to date. The second message is that it works, okay? Protein energy malnutrition, or PEM, is quite commonly seen in our patients who have a very chronic, very difficult cause of IBD. I'm sure all of us here have some patients who come in and they look very, very thin with a very, very low BMI. So this study specifically looked at patients with ulcerative colitis, not Crohn's disease. And what they found is that in patients with ulcerative colitis with protein energy malnutrition, they were actually more likely to have infectious complications, which actually makes sense. So the take-home message for this study is that if you have patients who are thin, they look like they haven't been eating well, very low HB, had ulcerative colitis, and is admitted to a unit, right? Start to be mindful, be aware that these patients can get infection, and start antibiotics early if you have a suspicion that something is going on. And we all have patients who are admitted for Crohn's disease or ulcerative colitis. This study looked at patients who have Crohn's disease and who require surgery, and then they look very thin. And then you always think, should they receive EEN before they go for surgery? The surgeon will ask you to do it, and you think whether, then you have to balance the timing. Does the patient need it urgently? Can the patient wait for 1 or 2 more weeks before undergoing the surgery that's planned for them? And this is a meta-analysis which shows that pre-op EEN, exclusive enteral nutrition, before surgery does help actually. So it reduces the rate of infection especially intra-abdominal septic complications and skin and wound infections, which are actually the two most common problems and two things that the surgeons don't really like. So, but there's no effect on the duration of surgery, length of bowel resection, or surgical blood loss. But as you know, post-op complications and infections can be quite troublesome, and some patients actually have a hard time with that. So, pre-op EN may actually be something that you have to think about before you send the patient for surgery, especially in patients who need them. So this is a theme that's been going on for the last few years. We've seen papers which show that if patients who have IBD and they are on opioids to manage their abdominal pain, it's associated with higher rates of resection, higher rates of death in these patients. So I don't know how often we use opioids for IBD in Southeast Asia. I think in Singapore we don't use it very often. We are quite strict with it. I suppose it might be the same for in Thailand as well. So this was a nationwide cohort study in Denmark. And what they showed was that they wanted to see if using tramadol was a better option versus using opioids. And what they found was that if you use tramadol, it was associated with lower odds of severe infection, bowel obstruction, and also mortality versus using traditional opioids in IBD. So if a patient is dependent on opioids, tramadol may be a better option for them actually to manage the abdominal pain. But also, don't forget that if there's underlying inflammation, the treatment should be still targeted towards inflammation. And no one should be on tramadol or opioids for long term. Something is wrong if a patient requires that. So NUT-T15, TPMT, and HLA variants. So this study looked at various genetic variants that are associated with thiopurine-related adverse drug reactions. We still use thiopurines very often, still very useful in many patients, especially ulcerative colitis. And the occasional Crohn's disease patient will still do well on azathioprine. So what this study shows is that we know that NUT-T15 is very common. In patients with East Asian descent, about 1/4 to 1/3 of these patients have these variants. And in South Asian descent, about 1 in 7 of these patients have these variants. And we know that these are associated with low white blood counts or leukopenia. And what this study showed is that some variants, HLA haplotype variants, are also associated with the risk of pancreatitis. So this study actually says that, well, these variants exist, and we should really consider screening them for these variants before we start azathioprine for them, and to be a lookout for these complications when they happen, if they happen. And this is the next segment, which looks at disease-related outcomes, including recurrence after surgery, comorbidity, hospitalization, and disease assessment. So this is a pretty interesting study. So treat to target, everyone here knows about it. We've all been talking about it. So this looks like a quality improvement project, which I think is pretty neat. So sometimes you hear people talking about it, but what if you institute it in your practice? Does it make a difference? So there are only three checkboxes that these practices had to do. The first one was treat to target, discuss with your patient. Second one was objective assessment for inflammation, perform. That means, do you have a CRP or do you have a calprotectin on hand? And the last one, is there intention to change treatment when the target is not reached? So just these 3 questions. Maybe for every patient that you see, you think about these 3 questions. And this was a quality improvement project. And what they found was that by implementing this, the TDT score over 12 months actually improved from 20% to 50%. And they also went on to study if this had an impact on the patient. So they wanted to see if sites that implemented this treat-to-target system, the patients do better. So they looked at endoscopic remission and corticosteroid-free clinical remission. And although there was no statistical significance, you can see the trend. There was a slight trend to some improvement. So having these thoughts and ideas in your brain when you see the patient could potentially lead to better outcomes for them as well. So we all know about the LYRIC study, 5-year follow-up study has been published. So a LYRIC study compared the outcome. I think we'll talk about it this later when Julajak is presenting one of the cases. So this is the Danish Melody study, which is actually answering the same question but asked in a different way. So the Danish Melody study, which is presented here, is looking at the Danish nationwide registry, and it's a retrospective study as a result of that. And what they compared was that patients who have ileocecal Crohn's disease, they are very short segment, inflammatory and they underwent surgery versus patients who had anti-TNF as a first-line treatment, and they compared outcomes over time. So it's a composite outcome of hospitalization, peritoneal disease, steroid use, or Crohn's disease-related surgery. And this study actually found that primary resection tended to have less complications after many years of follow-up. And this data actually supports what the LYRIC study found. So do consider surgery if, for some of your patients if there's expertise in your center. That means you have a surgeon who is willing and who is good in doing it, because complications can happen as well. So if you were to send your patient to surgery, then what kind of anastomosis should your surgeon use? Should you use a conventional, stapled functional end-to-end anastomosis, or a side-to-side anastomosis that most surgeons normally use? Or should you use a Kono-S anastomosis, which is a hand-sewn anti-mesenteric functional end-to-end anastomosis, whereby a longitudinal incision is made upstream and downstream to the anastomosis, and this forms a supporting column as well. So you have a widely patent lumen, and it is suggested, and there are studies that show, earlier studies, same group, which show pretty good outcomes. So this study shows that at up to 43 months, actually, the risk of clinical recurrence and surgical recurrence is lower in patients who receive Kono-S anastomosis. So if you speak to a surgeon, they'll tell you if it's something that can potentially be done, and usually takes maybe about 45 minutes to 1 hour more for the surgery, but this leads to quite significant outcome over the longer term, so that may be a worthwhile investment for these patients. But if you have done scopes for these Kono-S anastomosis, right, and you're assessing the Rutgers score, you realize that sometimes it's quite difficult to find the lumen, because it's not what we are traditionally used to. This one very quickly shows, this is a study which shows that the rates of small bowel cancers, non-Hodgkin's lymphoma, and biliary tract cancers have risen in our patients with IBD over the last 25 years. But also remember that the absolute numbers are very low. So it is not something you commonly see in your practice. Occasionally you see 1 or 2 in your lifetime, but it's just something to bear in mind. So this study looks at the endoscopic balloon dilatation in patients with Crohn's disease. So compared to undergoing surgery, EBD is something that is potentially useful in patients with short segment strictures. So what this study shows is that at the end of 1 year, the requirement for surgery will be about 10% now. So 1 in 10 will require surgery at the end of 1 year if you perform EBD in your patients, which means 9 patients will avoid surgery. So this is an option in patients in whom you really don't want are poor candidates for surgery. The complication rates are about 1% for bleeding and perforation, which is kind of in keeping with what we know. So very quickly on population health, so there are 2 studies. This study shows that patients with IBD have a slightly higher risk of developing stroke. The hazard ratio is about 1 to 1.2. It's not very high, but if you put the numbers together, it is fairly significant over time. So the take-home message for this is that in your busy clinic, you are busy trying to do everything. You probably have to think about or get the primary care physician to screen for risk factors such as smoking, LDL control, hypertension, and diabetes as well. You may not have to do the treatment, but something to think about and encourage your patient to do so. Similar take-home message for this. Patients are at higher risk of developing cardiovascular complications. Okay, so similar risk factors also, and similar things to target as well. So this is a study which was done in some tertiary centers, highly selected population of patients with IBD. So if you know ARFID, which is avoidant restrictive food intake disorder, it's a bit different from anorexia nervosa. These patients don't have a fear of weight gain. These patients don't have body dysmorphic disorder. So whereas patients with anorexia nervosa will have those features. So this was a multi-center cross-sectional survey and found that ARFID is actually associated with more GI-specific anxiety and a higher visceral sensitivity index scores in patients with Crohn's disease as well. So if you are practicing in a tertiary center, very highly selected population, about 1/5 of your patients will actually have ARFID. And what about patients with irritable bowel syndrome? We know that maybe about 1/5 or 1/4 of our patients with IBD will have IBS as well. And And we know that now in Rome 4 criteria, abdominal pain is included as a diagnostic criterion in IBS. So what this study showed was that these patients were screened for with a questionnaire and they had to fill in the scores. And what they found was that in patients with endoscopic remission, IBS prevalence is quite low. I think because patients with endoscopic remission are more likely to have, less likely to have abdominal pain. So this is something that this study found. So if you treat your patient well, pain scores go down, IBS symptoms get better as well. Something that we don't ask for routinely in our clinic, which is sexual dysfunction or sexual function. And what this study showed was that in patients in whom you treat their IBD and their IBD gets better, they were less likely to have issues with sexual function as well. So again, this is something that is probably overlooked in our practice, in our busy clinic practice, and we don't really screen for this. But I thought this was an interesting study. And then we have two more slides on pregnancy and IBD. The first one shows that, we have patients who are younger and patients who are of childbearing age. And what about women who have IBD? So the first take-home message for this is expected. Women who are pregnant and have IBD are more likely to have increased healthcare utilization. So that's pretty straightforward. And what was interesting, perhaps not that interesting, was that the most common reason for hospitalization in these patients was venous thromboembolism. So the message for this is that if a pregnant woman, be aware that venous thromboembolism is something that is that can potentially happen. And this is related to the first poll question, I guess. So this was the PICCOLO study, which is an Australian study which looked at maternal and fetal outcomes in patients with IBD. So drug levels were taken during preconception, first, second, and third trimester delivery, and also postpartum. And what they found was that the clearance level may vary a little bit, but it had no material difference. So if you give this medicine, clearance level will change. But at the end of the day, it doesn't really make a difference to the mother or the baby. So this is reassuring data. It is, again, in keeping with what we know from the Piano registry in the US, and that if patients who are on treatment with Vido and ustekinumab, it is okay to treat through without fear of added risks. And routine drug level monitoring is not routine for these patients. If you already do it, Vido and ustekinumab levels are not available in Singapore, so we don't do it anyway. But if you have it available in Thailand, you don't really need to do it as well. So a few take-home messages from this segment of the Best of DDW. Upadacitinib, I think Ida has mentioned before, is efficacious for Crohn's disease, including perianal disease, so that is good data. But this is a post-hoc subgroup analysis, prospective data. What would be interesting is to have proper prospective data, because to date, the strongest data is still on infliximab. And if we have data on upadacitinib, I think that would be great. It's good to have some studies in surgery in Crohn's disease, especially primary ileal cecal resection and Cono-S. It's quite difficult to do studies in surgery, but we know that surgery is effective in many patients with Crohn's disease, in whom our medicines really don't work very well at all. And the last point is that ustekinumab and vedolizumab is probably safe in pregnancy, probably meaning a very high chance that it's actually okay. So with that, I'll end the Best of DDW segment, and we can have a Q&A discussion if there are any questions that you have, any queries we can discuss. Okay, I really shouldn't touch this, sorry.
Any
questions? Being electrocuted.
Hello. Any question? Okay, no question. Thank you very much, Malcolm, for your excellent talk. I think there are many important studies that we can apply to our clinical practice. That include the study that you show in your take-home message, and also the benefit of EBD and the risk of stroke and CVD in IBD patients that we should be aware of. So thank you very much. So we're going to move to the next session, which is the UEGW highlight. The first part will be delivered by Professor Ida Hilmi. So please, Professor Ida.
So much. So I think I'm just going to go straight on. So I presented data from the best of DDW, which was the power study. This is done by Stefan Schreiber's group. And what I said was that the primary endpoint was not met, all right, which was a clinical response at week 16. So in UEGW, subgroup analysis were looked at. And again, as what we said before, the primary endpoint here, was not achieved, all right? Although numerically, you can see that those with inadequate response who received IV loading as opposed to continuing subcut numerically did have a response, but it just didn't meet statistical significance. But in this particular list of abstracts, it was actually looking specifically, and what they found was that when you actually had multiple failed biologics, especially 3 or more, then you are even less likely to have any benefit from induction with reinduction with IV ustekinumab. And this is actually looking specifically across the board, clinical remission. So again, clinical remission at week 16 and normalized CRP and fecal calprotectin. However, I do want to point out one thing, though, that although the primary endpoint was not reached, you can actually see here that the normalization of CRP and fecal calprotectin actually was reached. So if you look, it did reach statistical significance. So my take home for this power study, which is actually looking at IV reinduction in patients with an inadequate response to ustekinumab, is that it probably does work, but maybe was not powered to reach statistical significance. And I personally also, I mean, again, still use it. I don't know if you do, Julaja, in patients who I see a slight loss of response. I do tend to reload them with IV reinduction, although this particular power study did not meet its primary endpoint. And as I said before, the other option, as mentioned in Best of DDW, was dose escalation to 4 weekly instead of 8 weekly. So, and I think, so essentially this is the same thing really, which is results from the power study. I'm sure most of us are familiar with the STRIDE guidelines, and one of the endpoints now that people are looking at is not just Mayo 0 or Mayo 1, i.e. endoscopic remission for ulcerative colitis, but actually histological remission. In other words, if you look at whatever scoring system, for example, the NANSI, that you actually shouldn't be seeing any microscopic inflammatory activity, especially infiltration of neutrophils and so on, acute inflammation in patients with ulcerative colitis. That's not been put as the main guideline yet, but perhaps something of the future. And I think this is a study that actually shows this in more detail. So this is what we call the term of disease clearance, where you don't just have endoscopic improvement, but histological improvement. In other words, when you're actually biopsying them, you're actually not seeing any inflammatory activities. And this unified 4-year result study, you can actually see, and those, of course, who did not achieve any remission, be it symptomatic, endoscopic, or histological, then of course the percentage of patients in symptomatic remission was low. But if you actually had this so-called disease clearance, you can see patients up to 4 years had a very high rate of symptomatic remission. This is essentially the same thing, but presented another way. In other words, patients with this disease clearance had a longer time to treatment failure. Now, we want to talk a little bit about extraintestinal manifestations, actually. So, of course, the one that usually works for everything, right? Especially is the anti-TNFs, because we know anti-TNFs is a systemic, acts systemically, and it can work across the board for most of the extraintestinal manifestations. And by that, of course, usually it's infliximab and adalimumab. But I think upadacitinib, sorry, it didn't come out well, I think is showing promise in that as well, because upadacitinib actually has good data for spondyloarthritis. But other drugs may not be so good. So, for example, if you look at ustekinumab, all right, it really doesn't have good effect in terms of the axial spondyloarthritis, but does have effect on peripheral arthritis. Vedolizumab does not, unless the arthritis is very, very gut-driven. And in fact, there have been some de novo cases of arthritis that have developed, that have been presented when starting vedolizumab as well. So this is some of the things that we want to bear in mind if we have patients with significant extraintestinal manifestations. So one of the UEGW abstracts that was presented was looking specifically at ustekinumab in the extraintestinal manifestations, all right? And this is called the Ulysses study, real-world data. And this one actually shows whether or not there's improvement, no change, or worsening. So if you can see here that so peripheral arthritis tend to parallel disease activity or gut disease activity, whereas axial arthritis do not. So what happens is that in those where the disease, where the EIM parallels disease activity, you actually get improvement with ustekinumab. But in those where the EIM does not parallel, in particular, axial spondyloarthritis, then actually you had worsening on ustekinumab. So that's, I think, a very important message, that in those patients with coexisting axial spars, you probably, axial spars, you probably should not be using ustekinumab. And of course, infliximab, adalimumab is a good option, but upadacitinib is showing good action as well, all right? But for the others, then it's no problems to use a drug like ustekinumab. Vedolizumab, you probably should be a little bit careful in any forms of arthritis based on some of the data that shows that you could develop, de novo spars, all right? So these are some of the, so that's the take-home message from this. In the Best of DDW, we talked about a prospective study looking at vedolizumab for post-operative recurrence. So post-operative recurrence we've been talking about a lot actually, and while Malcolm has been saying how amazing ileocecal resections are and it's good a choice, but unfortunately, I would say to you that that would be great only if we had no postoperative recurrence. And hopefully that will happen with using of Kono-S, mesenteric resections, and so on. But unfortunately, as of now, it's a reality. Vedolizumab has been shown to be a benefit. I told you POCA study, which is the landmark study, has shown. And this study is looking at ustekinumab and adalimumab, and it's an observational study, really prospective in Belgium and France, and actually found that the endoscopic recurrence is actually similar between ustekinumab and adalimumab. But I think what I would say is a bit sad is that even with biologic therapy, there is still a risk of endoscopic recurrence. And I think that's another important take-home message, that even with the best prophylactic therapy, endoscopic recurrence is still, an issue. I think I will do this poll question now. All right, so can we take a vote on this? So we have just a standard somebody with moderate ileocolonic Crohn's disease, no perianal involvement. What are you going to choose? Okay, time's up. So I think this is interesting. All right, this is very interesting. Okay, so let's look at the data. So this is the ANIDA study, okay, which is a large registry, all right? It's a retrospective multi-center study, which actually looked at patients who are bio-naive, all right, who didn't actually receive any advanced therapy. And if you can see this, you actually found that ustekinumab, and this is both for ulcerative colitis and Crohn's disease, although more so for Crohn's disease, of course, was that ustekinumab showed a higher persistence and lower treatment discontinuation rate. So if you remember what we presented in terms of ulcerative colitis and the study from Best of DDW, where basically in bio-naive patients, there was no difference in persistence, but in bio-exposed, ustekinumab showed the highest persistence. But in this one, even as first line, ustekinumab was showing a higher persistence and lower discontinuation rate. In other words, most patients just remained on the drug at 56 weeks, all right, for both Crohn's disease and ulcerative colitis, and this is presented in another way, all right? So the persistence was higher. Okay, so also, if you actually look at the effectiveness, although they're quite similar, ustekinumab was more effective compared to vedolizumab to induce early endoscopic and histological remission, and these are in patients who have failed at least one anti-TNFs. So again, if you can actually look across numerically, you can actually see endoscopic remission was higher, histoendoscopic remission, which we talked about, Hemi just now, was higher, and a slight numerical advantage in steroid-free clinical remission as well. What about perianal fistulizing Crohn's disease? So I already mentioned that as of now, infliximab, according to the guidelines, is the recommended choice. Anti-TNFs, in particular infliximab, is the recommended choice for perianal fistulizing Crohn's disease. But we already showed data that upadacitinib was showing good data. And what if, once the infliximab fails, what if you develop antibodies, to infliximab? What do you do next? And in this particular study, looking at those with failure to anti-TNFs, they actually found that you can use ustekinumab, and that ustekinumab actually showed the highest rate of clinical response, clinical remission, fistula improvement, and fistula healing, all right? And this is the second-line cohort and the third-line cohort, so you can see consistently that ustekinumab was better than vedolizumab and anti-TNF. And I guess the most common anti-TNF that used after infliximab would be adalimumab. Let's move on to, okay, so I'm going to stop there actually, because I think the rest is all for Malcolm, who is going to be talking about guselkumab. So I didn't write it down. I'm not as organized as Malcolm, but I wanted to take some take-home messages. So again, like what Malcolm was saying, I think upadacitinib is a very potent small molecule, very promising one. And what I think we're seeing is that there's very good data for it in acute severe ulcerative colitis as rescue therapy, in perianal fistulizing Crohn's disease, and what I think is also interesting as well is in the spondyloarthritis as well. So watch this space with upadacitinib when it comes out. I think the second take-home message that's come out in a lot of these abstracts is that I think ustekinumab and JAK inhibitors is the preferred biologic, is the preferred choice for biologic-exposed patients in ulcerative colitis, and I think it suggests that it is. Ustekinumab is also the preferred choice for biologic failures in Crohn's disease, and I think there's a lot of real-world data to support that now over vedolizumab. So I think that that data is quite consistent now. In bio-naive patients, I guess you can use any of the advanced therapies, all right? And it's still head-to-head studies are not available. But I think when you look at across the board again, persistence seems to be highest among ustekinumab. I do believe I've taken part in a lot of the IL-23 studies, and I think the pure IL-23s like guselkumab, risankizumab, mirikizumab is going to show even better data than the current available therapies because the early studies, the landmark studies haven't come out yet, is showing that, and they'll probably be, I think, even better than the IL-12/23 inhibitors. So with that, I thank you.
All right, so I'll move on to my segment of the UEGW highlights. Again, I will start talking, I'll start with introducing a few poll questions. These are more like knowledge questions, I guess, more rather than understanding individual practices. So this is one. Anti-P19 therapies are more effective than anti-P40 therapies in moderate to severe Crohn's disease. True or false? All right, so yeah, I think the message has come across, in the last few years, the message has been, well, perhaps anti-P19 therapies are more effective than anti-P40 therapies that we know. And the second poll question I have would be, herpes zoster is an infectious complication that we worry about when we use tofacitinib in patients with ulcerative colitis. And what about in JAK1 inhibitors? So is herpes zoster still a problem if we use JAK1 inhibition? So true or false, herpes zoster is something we worry about in pan-JAK, but not in JAK1. Okay, so yeah, a bit more balanced, right? About half of us think that it is, and a bit, and the other half do not think it is. So I'll move on to my parts, which is the UEGW highlights. You realize that these are more therapeutic driven compared to the best of DEW. So we just wanted to highlight a few pivotal studies that came out and some things that we can all learn from. So the Galaxy 1 study was a study of goselkumab. It was a phase 2 double-blind study for patients with moderate to severe Crohn's disease. If you look at the design, about 1 in 5 of these patients actually got placebo. There was a ustekinumab reference arm as well, and there were 3 goselkumab arms with various doses. And if you look at the study, this is actually a treat-through design. And this looked at the long-term extension, which was later on, after the induction and after the maintenance. And about half of these patients were actually biofailures. So what they did was that because the numbers were not huge, and all these numbers are presented with nominal p-values, so they combined all the patients who were on goselkumab long-term maintenance or the extension arm, and they compared that to patients who had ustekinumab maintenance as well. So if you look at how they analyze the data, so there were a few ways you can analyze this kind of data. So the first one is if you have all randomized patients. So if you look at the lowest numbers, which is all randomized patients in goselkumab and ustekinumab, so these are the patients whom they got at least 1 dose of the drug from induction. And then if you look at the top one, which is patients observed. So if they were analyzed as observed, that means these patients made it to the end and were analyzed then. So these are patients that are potentially the ones that do better. So if they do better, they are kept on the drug and they reach all the way to the end. And then you have the in-between, which is patients in long-term follow-up non-responder imputation, which is NRI for short. So NRI generally is the more conservative estimate compared to as observed, because non-responder could be patients who are stopped treatment because the treatment don't work, or also patients in whom they have missing data. So if you are very optimistic, you look at the as observed. If you are a bit more pessimistic, you look at NRI. The truth is probably somewhere in between. If you compare the goselkumab patients versus those in the ustekinumab reference arm, you could see that there is potentially a numerical difference between these 2 groups. And if you look at clinical remission, if you use PR2 remission, which means that they have a very low abdominal pain score and also stool frequency scores, you realize that the numbers are pretty similar compared to the earlier slide, which used CDAI as a reference for clinical remission. And how about looking at all endoscopic endpoints? If you look at endoscopic response and endoscopic remission, if you look at the very, very last column all the way on the right, you can see that perhaps in endoscopic remission for goselkumab, it's roughly about 1.8 to 2 times more effective than ustekinumab. And that's an important number to remember. So perhaps an anti-P19 therapy, when you use goselkumab versus ustekinumab, is probably about twice as effective. And this is an important number to remember, or important ratio to remember. So when we look at the infectious complications, safety signals, again, no new safety signals for this class. If you are looking at papers for safety signals in anti-P19 therapies across the board, risankizumab, goselkumab, mirikizumab, it's actually a bit boring because really there's nothing to talk about. So as a class, they seem to be very, very good and very, very safe and very, very promising in our patients with Crohn's disease and ulcerative colitis. These patients actually had relatively low rates of discontinuation, very good safety profile. So that's the take-home message from this study. And in some of our patients, when we treat them and then they have some response or very little response, should you continue treating them or not? It's always very difficult, right? You don't know whether should you continue or should you increase the dose or should you change treatment. So in patients with guselkumab, some of these patients actually did not respond to the initial induction dose when they looked at them at week 12. But because of the treat-through designs, a lot of them actually continue on into subcutaneous maintenance arm. And they actually analyzed this and showed that these patients who were non-responders actually had longer disease duration, higher proportion of these patients were biofailures, and higher SCD score. So these are the patients which traditionally tend to do poorer with treatment. But what if we were to treat through? So that means if they were given induction, non-responders, and you treat through, are you still able to get a response from them or not? So in this study, it showed that actually it is possible, even if you use ustekinumab or guselkumab, at the end of 1 year, you can get a CDI response, which means a reduction of more than 100 points. And looking at the outcomes at week 48, at the end of 1 year, so a fair number of them can get PRO remission with guselkumab, about 40% compared to about 23% of them. And also you can get endoscopic response in about a third of them. So this study actually supports the use of, if you use guselkumab in future, if there's non-response at 12 weeks, consider treating through subcutaneous guselkumab, and you may get a response at the end of 1 year. So something to think about later on in your practice. So this is probably the study, the highlight of UEGW this year if you have attended it. So this is a sequence study. So in short, this is a double-blind study which compared the use of ustekinumab versus risankizumab, patients with moderate to severe Crohn's disease. And it's also important to remember that one of the inclusion criteria is that they had to fail an anti-TNF therapy before. So these patients were actually probably selected a more refractory group of patients already. And there was also a mandatory steroid taper, which is quite common in studies these days. And they were all centrally read as well. So something to understand from this study is that they had two primary endpoints. The first primary endpoint was non-inferiority halfway, which is at week 24, and also a superiority. So they're at week 48 for endoscopic remission. So it is important to understand that in non-inferiority studies, there are two ways to interpret it. One way is non-inferior and non-superior. The other way is non-inferior and superior. So in this study, it actually showed that risankizumab was superior to ustekinumab in both primary endpoints, where there's non-inferiority in terms of clinical remission at week 24 and endoscopic remission at week 48 was superior. And the discontinuation rates for this study in the risankizumab arm was 10% and about 27% in ustekinumab. And this is also important. We always want to see good secondary endpoints also. If all the secondary endpoints are consistent with the primary outcome, then you know that this is probably very close to the truth or it's a very real signal. So again, no new safety risks were identified, consistent with what we know with risankizumab and ustekinumab. So we don't really have a lot of head-to-head trials in IBD, CView being one of them, Varsity being another, and Sequence will be another one. So this is something that you will probably see in the next 2 or 3 years before the next big head-to-head study comes out. So advanced, motivate, and fortify studies have already been published, so they demonstrated the effectiveness of risankizumab in moderate to severe Crohn's disease. So in this study, patients were also, data on their EAMs was also collected. If you look at the right side, so these were investigator-filled questionnaires. So it's actually a very simple EIM form. If you look at it, it's either a yes, no, yes, no, yes, no, and it's subjective. So something to keep in mind when you interpret the findings of this study. So for example, there are no objective markers for this EIM form. So what they found in patients with moderate to severe Crohn's disease with these EIMs, and if you treat them with risankizumab, did it improve their EIMs as well? So the first take-home message for this is that most of the EIMs in this study was driven by peripheral arthropathy and axial arthropathy and anemia. And if you look at the outcomes of these studies, again, these p-values are nominal p-values, but it seems that if these patients who receive risankizumab, and if they had axial arthropathy and anemia, these extra-intestinal manifestations, these patients will do better in these aspects. And this is a pretty simple study, so this is a post-hoc analysis of patients with EIM. So risankizumab may be effective in patients with these EIMs and Crohn's disease. So another risankizumab study, this is an INSPIRE study. So we know that it's efficacious in moderate to severe Crohn's disease. What about in ulcerative colitis? So this look at induction data for ulcerative colitis. So induction data is usually at week 12. So patients receive intravenous risankizumab. And the study population is pretty consistent. Just note that none of them had previous exposure to ustekinumab. And then the usual secondary endpoints. So if you look at the primary endpoint, which is clinical remission per adapted Mayo score, just to remind ourselves, adapted Mayo score is your Mayo score without the physician global assessment, without the PGA. If you know the PGA is very, very subjective, so it's probably good to have an adapted Mayo score rather than a full Mayo score. And across the primary endpoint, which is clinical remission and clinical response at week 2 and week 14, risankizumab is effective in patients with moderate to severe ulcerative colitis. And across endoscopic and histological endpoints and PROs at week 12 is also effective as well. Something to note here would be the bowel urgency. It's something that you'll see more and more in trials. It's becoming something that's very important in our patients with ulcerative colitis. And if you read the mirikizumab study, it was really the study that included bowel urgency as an important secondary endpoint, and this will continue to be so. So even if you look at different types of endoscopic endpoints and combine mucosal remission, histologic remission as well, risankizumab seems to be better than placebo. So we'll look forward to the maintenance study for risankizumab in moderate to severe ulcerative colitis. So quite briefly, so mirikizumab is an anti-P19 therapy. If I'm not wrong, it's already licensed for use in the US by the FDA. So it's the first anti-P19 therapy for ulcerative colitis. So in this study, it looked at the open label long-term extension. So patients who were in Lucent 1, which is the induction study, Lucent 2 is the maintenance study, and at the end of Lucent 2, if patients remain well and remain in remission, they got invited to join Lucent 3, which is the long-term extension study, where patients receive open-label mirikizumab, 200 milligrams subcutaneous every 4 weekly. And usually long-term studies is basically to determine the durability and also if there are any new safety signals as well. So this was supposed to go on for a bit longer, but this is an interim 2-year analysis. And again, this data, when you look at these data, they are not powered to show any significant differences or whether there are significant differences or not, but they are all reported descriptively and numerically. So this used non-responder imputation, which is, if you remember, is probably the most conservative estimate. So when they looked at all these outcomes and they divided them into biologic failed and non-biologic failed patients, across the board, you can see that there's fairly good durability at up to 2 years. And there doesn't seem to be any difference whether they are biologic failed or not, which is quite consistent with the data we know from other anti-P19 therapies. And if you look at histologic and endoscopic endpoints, you can see across the board, they look fairly similar as well, whether they are biofailures or not. So a few studies from upadacitinib. This was in patients with ulcerative colitis who went into the U-Activate, which is the long-term extension part. So patients were enrolled in U-Accomplish and U-Achieve. They went into U-Achieve maintenance, and they went into a U-Activate long-term extension. So this is supposed to go on for about 5 years, and this is another interim analysis at 2 years. And what is important to know is that at the end of maintenance, those who were on 15 milligrams a day, about 70% remained in remission. whereas those were on a higher dose of 30 milligrams a day, 80% remained in remission. And this data was analyzed as observed. So as observed means very optimistic. That means you're playing the winners. People who do well continue to stay on in the trial. That's why you see as observed data is always a bit higher than the NRI. You cannot compare like for like. So at the end of 2 years, you can see a majority of them actually do remain well in endoscopic remission, which is very good. Safety signals for small molecules are always a little bit more concerning than anti-P19 therapies. And the usual, we look out for zoster, especially JAK inhibition. We look out for neutropenia and CK elevation. So in patients with JAK inhibition, CK elevation happens in about 5% of them. But the CK elevation is generally not clinically significant. You don't really need to worry about it. But zoster is usually a problem because zoster can be very, very painful. So the answer, I guess, to the first one of the questions was that, yes, in JAK1 inhibition, you still get a problem with zoster. The other skin problem that you get quite commonly in JAK1 inhibition is acne. So if you have young patients, they can be quite troubled by it as well. And of course, with this, there is no new safety signal. All these are consistent with what we already know before. There were 2 events of malignancy. One of it was a papillary thyroid carcinoma, and the other one was the squamous cell carcinoma of the uterine cervix. So these are cancer events that you need to know when you're talking to a patient, although it doesn't happen very often. And what about data for Crohn's disease? Upadacitinib in Crohn's disease has been published this year in New England Journal of Medicine. The lead author was Dr. Edward Loftus. So the primary analysis was done and is published. At that point, they recruited about 500 patients, and that was what they set out to do. The purpose of this abstract was that they continued recruiting. So in the end, they got 673 patients, and they wanted to see if what they found after finishing recruiting everybody, was it consistent with what they published. The long and short answer is yes, it's consistent. So I won't belabor the point. It just reinforces what we already know, and including clinical outcomes and secondary endpoints. So nothing new here. But what you want to know is, well, is it safe or not? If you have more numbers, generally you get more safety problems. Right? Generally no difference, but again, you want to know the key safety signals. One was that in patients on 30 milligrams a day, there was a case of a hepatic vein thrombosis, which is again something that we think about when you're using JAK inhibition, right? We worry about VTE. And it was adjudicated to be due to an active flare of Crohn's. And there were some cancers in the studies as well. There was a patient who had ovarian metastatic cancer, metastatic ovarian cancer, and 2 other cancers which were cancer of the colon, and also a breast cancer patient. So there were 3 cancers in the whole study of about 673 patients, and 1 hepatic vein thrombosis. So because of this is another study, it's a different one, but similar group, they looked at it from another angle. So because of the nature, because of how the study was designed, so this was not a treat-through design, this was a randomized responder design. So which means that if you enter the trial, induction, and the patient got achieved remission, right? And so if they achieved remission or they responded, and then they will re-randomize again. So by virtue of that, right, some of them will be randomized into a placebo arm. That means they did well, and some of them will end up on placebo arm. And that is effectively, you think about it, is a withdrawal kind of design. So what they did was that in these patients who were randomized to a dose of 15 milligrams or were randomized into total withdrawal, were they likely to have a flare or not? You would think that yes, and the answer is yes, they do. But if you treat them again later on, will you be able to recapture the response or not? And how they define loss of response was by, number 1, clinical symptoms. Patient had symptoms, start to have symptoms of Crohn's disease. And the second thing is that they had to have objective markers of inflammation, which is either a high CRP, high calprotectin, or endoscopically active disease. So these are real flares. And what they found was that the first take-home message is that if the patient responded well and you withdraw it, a lot of them are going to get loss of response quite quickly. And if you you start them on a lower dose of 15 milligrams a day, about half of them will lose response as well. So if they lose response and you reintroduce them with upadacitinib 30 milligrams a day, what does it mean to them? So it shows that it works, all right? So if they have a flare after they have a dose reduction or they have withdrawal, and if you reintroduce at a dose of 30 milligrams, it will work across all the points, endpoints such as clinical response, remission, and also steroid-free remission as well. And of course, you will want objective markers of inflammation to see if the inflammatory burden does get improved as well. So the secondary, the other parts of this was that, yes, it does. So if you reintroduce upadacitinib, the CRP level will come down and the fecal calprotectin level will come down as well. So, so the take-home messages from UEGW highlights would be, yes, anti-P19 therapies are effective and safe in IBD, and they're probably better than anti-P40 therapy if it's available in your jurisdiction. And the last one, which is upadacitinib, is effective in IBD. We have longer-term data of up to 2 years, and we need to know that the risks of zoster, CK elevation, and neutropenia is dose-related, and people always ask what dose should you use lah. So the answer always is you should use the lowest effective dose. In some patients, you can use a lower dose. Some patients, you need a higher dose. But with a higher dose, you know that you need to worry about these complications. So with that, I'll end my segment. And I guess we can open the floor to discussion for anyone who have any questions. And we can have a discussion with, about any of the slides that were presented today.